Good evening all. I am presenting on the topic diabetic macular edema under the guidance of Dr. Geeta.
Excuse me, Dr. Shana. Can you just open your video? Yeah, now start presenting.
Diabetic macular edema is retinal thickening or presence of hard exudates within one disc diameter of the center of macula. It is the most common cause of visual loss in diabetic patients. CSMA is defined as thickening within 500 microns of the center or hard exudates within 500 microns of the center if the adjacent retina is thickened, or thickening of one disc area if it is coming within one disc diameter of the center. Coming to the pathophysiology, hyperglycemia is the most important risk factor which will lead to increase in hypoxia, reactive oxygen species, which will induce inflammation. So cytokines will be activated, which alters the blood-retinal barrier and increased vascular permeability. Breakdown of inner blood-retinal barrier happens due to three mechanisms: breakdown of cell-to-cell junction, pericyte loss, and basement membrane thickening. The cell-to-cell junction breakdown is due to decreased occludin and cadherin levels between the endothelium and the chemokines which are produced by Muller and endothelial cells. Apart from the fundus examination, diagnostic modalities include fluorescein angiography, OCT, and OCTA. Fluorescein angiography is currently indicated in case to differentiate ischemic from exudative maculopathy, in case of focal macular edema, to guide laser treatment, to find CNP areas, and in asteroid hyalosis to view the if fundus view is poor. Based on the leakage patterns in FFA, DME is classified as focal, diffuse, and ischemic. Now, OCT is currently the gold standard for the diagnosis and monitoring since it is fast and non-invasive. Also, it helps in monitoring the effect of the therapy. Based on OCT, DME is classified as diffuse spongiform edema type, cystoid macular edema type, serous detachment type, and taut posterior hyaloid type. Certain OCT biomarkers to assess the visual prognosis include central subfield thickness, drill, and hyperreflective retinal foci. So the central subfield is the central 1 mm zone diameter centered around the fovea. Its thickness is a good predictive biomarker of visual acuity and response to anti-VEGF. Drill is disorganization or destruction of the inner retinal layer, which leads to abnormal visual processing. It's also a reliable biomarker for the assessment of visual acuity. Hyperreflective retinal foci appears as hyperreflective dots between the retinal layers, and it is an important imaging marker of retinal inflammation. Now, OCT angiography is another non-invasive tool to observe superficial and deep vascular layers of the retina. It is basically done to assess the macular vascularization and the size of foveal avascular zone. So here you can see that as the severity of the disease increases, the FAZ has been enlarged. Coming to the management, systemic management is the most important to control the blood sugar and other risk factors. Ocular management includes intravitreal approaches, anti-VEGF in central involving macular edema, and intravitreal steroids. Laser treatment is used in non-central involving macular edema. Then vitrectomy is another modality. Important anti-VEGF options are bevacizumab, which is an off-label option, very popular. It is very less expensive when compared to the others. Ranibizumab is another FDA treatment DME. Aflibercept is also FDA approved, which is used in a dose of 2 milligrams. Certain adverse effects associated with anti-VEGFs are endophthalmitis, intraocular inflammation, ocular hemorrhage, rhegmatogenous RD. Now, steroids can be used in DME to stabilize the blood-retinal barrier and down-regulate VEGF. It is indicated in refractory cases where we have no response to anti-VEGF. Then pseudophakic eyes, vitrectomized eye, more hard exudates at the foveal center. Then steroids can be used. Intravitreal triamcinolone acetonide and dexamethasone sustained release implants are the options available. But their adverse effects include elevated IOP, cataract, and endophthalmitis. Laser photocoagulation has been a conventional treatment used in non-center involving macular edema. So focal burns can be given to limit leakage from focal microaneurysms, or grid laser burns can be used if there is a diffuse leakage or diffuse breakdown of blood-retinal barriers present. Finally, vitrectomy can be used in treating eyes with the dot posterior hyaloid, which is adherent to the macula, to remove traction and improve macular oxygenation. It removes VEGF and pro-inflammatory cytokines. Thank you.
Yeah, now over to the panel.
Yeah,
Okay.
good.
Okay.
Sorry, carry on.
No. Dr. Vinay. Okay. See, what you told about intravitreal anti-VEGF agents. So, how frequently do you give these anti-VEGF agents? And see, will you be able to treat it just by using intravitreal anti-VEGF agents?
Sir, anti-VEGFs can be combined with laser also. After giving one injection, after 3 months, we can take another OCT to find if improvement is there. And after that, we can decide what to.
No, what should we advise the patient? Like, say this involves a lot of cost to the patient, increased number of visits. See, they're going to lose their salary on the day they're taking leaves. And so what should we advise? And is there any other injections that can be used for the management of macular edemas?
Is not very compliant, then intravitreal steroid sustained release implants can be an option.
The what steroid?
Dexamethasone sustained release implants will act for around 6 months.
Okay. So what is the problem with intravitreal steroids?
They can elevate the IOP, and in almost 50% of the cases, they will lead to cataract formation and endophthalmitis, another complication associated with steroids.
Okay, thank you.
Good presentation. No, so if you have a patient who has DME and also has cataract, how will you manage these patients?
Anti-VEGFs are options. We can use anti-VEGFs in pseudophakic eyes. Steroids are more preferred. Otherwise, anti-VEGFs can be an option.
You have a patient who has cataract and DME. Then how will you manage these patients?
Intravitreal injections, anti-VEGFs injection can be used
Along with the cataract. So you can give either the steroid or the anti-VEGF, right? Along with the cataract surgery. So you have a patient whom you've done a cataract surgery. They come to you in the post-operative period and the vision is a little lower. How are you going to differentiate that this edema is because of diabetes, or is it a CME induced because of cataract surgery, the Irwin-Gass syndrome? No? How can you differentiate them?
By seeing the OCT features, the OCT biomarkers, if the retina is thickened, we can correlate if it is due to
OCT alone. How is because your management is different. No? If you have a post cataract surgery CME, you don't you just have to give. You don't rarely ever need to give injections. No, it's important to differentiate. So what you can do is an FFA. If you have a leakage from the disc, it's going to tell you that it is a post cataract induced CME. Whereas if it's no leakage from the disc, then it's more likely to be because of your diabetes. Okay, good.
Yeah, Dr. Shana, very good presentation. It's a vast topic to cover in 4 minutes. Just I want to ask you, if you are a clinician, which investigation would you think is a must and first investigation apart from the systemic investigations? You face a patient with the DME, what would you go for first?
OCT definitely first.
OCT. Okay, so on OCT, what is the most important thing you will look for to guide your management?
The central subfield thickness is the most
Yeah,
important.
so more than like in your presentation also, you said central subfield thickness correlates to visual acuity. Does not always. Many studies have told it doesn't. But you will mainly see whether it is a center involving edema or non-center involving. That is the main classification. Okay, or whether there is a VMT. So if there is a associated traction, your management will be more towards
With vitrectomy.
surgical management. Yeah. So center in, suppose there is a patient with the PDR and DME. Is there any difference in your management? Has a proliferative diabetic retinopathy along with the DME?
DME has to be tackled first.
You will wait for the laser for PDR.
First,
Or what happens if you do the PRP for the PDR? What happens to the DME?
First, macular edema has to be controlled. Then only we
Controlled by
anti-VEGFs.
anti-VEGF. And then you do the laser. Okay.